Okay, good morning. Hi, students of batch 20. Now we will learn something about the peculiar joint associated with our profession, which is temporomandibular joint. Okay, so far you have been learning about the trauma and infections, but now we will go to the another important domain in oral surgery, TMJ. Okay, temporomandibular joint. In your daily practice, you would have there is a chance that you would encounter with an odontogenic emergency, which is like a pain or avulsion or something like that. Have you ever did you ever have you ever thought of getting a TMJ emergency in your clinic? The answer would be obviously yes. I think many of you would have guessed by now, and then we will see that as the lecture goes on. Okay, fine. So the thing which is most peculiar about TMJ disorders is that you have two options to choose. Two options to choose, which is like whether you to go for a surgery or not. Okay, by the rule, when all of your conservative treatments fail, only then we have to suggest for surgeries. So for that, first we have to evaluate the patient. You have to assess the severity of the condition. You have to try all the means of non-surgical management first. Then you can step up, and then when these things are of no use to the patient, and the patient keeps coming back with the same complaint without resolving, then you can think about the various surgical treatment options, of course, which you would be, as a general practitioner, you would be referring to the specialist oral surgeon. Okay, fine. Why this non-surgical management have been given so much of importance? Because many of the cases, the conditions resolve with non-surgical management. Very rarely the patient would require a surgery. So you have to know about non-surgical management also and surgical management also, what will be done there. But the non-surgical management is well within the purview of the general practitioner. Once you assess it completely, then you can start on this treatment to the patient. So it is imperative that we have to know what are all the options which can be used to treat the patient without actually going for a surgery. Okay, about this we are going to learn here. Okay, fine. So all the TMJ disorders present with pain. Okay, so just a brush up of the basic associated aspects of pain and facial pain and other things. Okay, pain is an unpleasant sensory experience perceived as arising from a specific location of the body, frequently associated with actual or potential tissue damage. In case of TMJ, this is going to be exactly near the joint. The patient will be pinpointing, but is it always going to be a pinpointing pain? No. In case the patient is having the muscle pain, the patient will not be able to pinpoint it. So about this we will learn as the lecture goes on. So we have the A delta fibers and the C fibers, which are responsible for conduction of sharp pain and then dull pain respectively. Okay, fine. So these are all the pain pathway. You have the nociceptors, which is the stimulating agents, which carries this. And I mean, once they are in contact with the afferent neurons, the pain gets transmitted through the dorsal ganglia and then dorsal horn of the spinal cord, where it crosses the to the opposite side at the spinothalamic tract, and then it reaches the thalamus, the somatosensory complex, and cortex and the limbic system, and then from midbrain it is getting radiated. I mean, it's getting relayed to the structures, the appropriate structures for the response. So from the central nervous system, we know that the sensation of the face is mainly supplied by the trigeminal nerve. You have the fibers getting relayed in the Gazarian ganglia, and then they extend till the pons and upper cervical to the upper cervical spinal cord. So how can this facial pain can present with the facial pain as such? The orofacial pain, which is a complex pain can present within all these forms: headache, toothache, sinus pain, eye pain, salivary gland pain, jaw muscle pain, jaw joint pain, and neuralgia, of which we are more bothered about. We are should be worried about in this lecture. We are more bothered about the jaw joint pain in association with the jaw muscle pain. Both these things are important. Otherwise, other than that, the headache, toothache, sinus pain, and eye pain, everything, that there's, the sources are different. So, but regarding the temporomandibular joint disorders, they present with normally this with muscle pain, myalgia, and the joint pain, arthralgia. Okay, fine. So how will you classify the orofacial pain? It can be because of extracranial origin, or it can be because of neural origin. It can be because of vascular origin, or simply it can be a referred pain because from the areas, other areas. Okay, and then of course the psychogenic pain. You cannot when we are not able to rule out the exact cause of pain. We should delay our diagnosis towards the pain because of psychogenic in origin. We cannot jump to the diagnosis of psychogenic pain because it comes in the very later part of our diagnostic ladder. Okay, so suddenly when we are not able to rule out the exact cause of pain, don't go for psychogenic pain at the first only. No, so only when you are ruling out everything, only when you are sure and certain that no other sources of pain exist, only then you go for psychogenic causes. Because when you suddenly jump to the diagnosis of psychogenic and start treating the patient, the patient, what we have from our experience, we feel that the patient is not so comfortable when you are just telling that it may be because of psychogenic pain. It has a very variable degree of acceptability by the patient. Okay, so just look for the proper sources of. Okay, fine. So the temporomandibular joint disorders. Okay, the patient who present with TMJ disorders will tell that when I am opening the pain may be during opening or closing or while masticating, or some have peculiarly the time preponderance. In my practice, I have heard the patients telling that the pain comes exactly at 2:30 p.m. I could not understand how come the pain comes exactly by 2:30 p.m. Then I asked the history of the patient, and the patient said that she will take a nap for some half an hour to 45 minutes after the post lunch. So once she gets up from the lunch, she gets up from the post lunch sleep, she gets the pain. So there are various reasons for it that we will come to know. Okay. So the applied anatomy of temporomandibular diorthoidal joint. You have two joints there. So you know that head of the condyle, the articulating surfaces are head of the condyle and glenoid fossa, and then you have two joints. These two joints cannot act independent of each other. While you can flex and extend your elbow, you can flex and extend both of your elbows independent of each other. Right elbow can be flexed and extended irrespective of the left, and then likewise the jaw. Likewise the leg, but you cannot open only the right side of your mouth, or you cannot close only the left side of your mouth. So both are interdependent, like husband and wife, both are interdependent. So it is called as a diorthoidal joint, and it is also called as ginglimo-orthoidal joint, which means that it is capable of producing both the hinge motion and the translatory motion. Okay, hinge motion, the mouth can open a bit wide to a small extent of width, whereas the translation movement, the mouth can open much bigger. Okay, and it is a synovial joint lined with cartilages. Okay, compound joint with an articular disc interspersing between the articulating surfaces, which are again covered with the cartilage. So you have this fluid, synovial fluid inside. In that sac, you have the synovial fluid. So these are all the articulating surfaces. Just to brush up with the basic osteology, you have that MF in the left side of the picture stands for mandibular fossa, and AE stands for the articular eminence. Here you have this articular eminence, it is concave, the glenoid fossa is concave, you have the mandibular fossa and the squamotympanic fissure. Squamotemporal fissure. Yeah. So the inner aspect of all synovial joints, including the TMJ, or there are two types of tissue. You have this articular cartilage and the synovium. This entire space is bounded by these structures, and then they form the synovial cavity, which is filled with the synovial fluid, which gives the lubrication during the joint movement. This is one important part in which there is an articular disc, which is biconcave in structure, in which there is a dense fibrous connective tissue, which is non-vascularized and non-innervated, which is an adaptation that allows it to resist pressure. So the central portion of the disc doesn't have a blood supply, doesn't have nerve supply. For obvious reasons, because that is going to be the buffer, or it is going to be interspersed between the two joints, which the articular surfaces are going to move over each other. So naturally it should not have the blood supply or nerve supply, or else it will get repeatedly injured. Okay, fine. So the disc can be divided into three regions anatomically. So anterior band, central intermediate zone, and posterior band, with the central intermediate zone devoid of nerve supply and blood supply, whereas the posterior band is rich in nerve supply and blood supply. Okay, fine. So you have the ligaments, which are collateral, capsular, and temporomandibular ligaments, which are considered functional because they serve as the major components of the joint into which this articular disc attaches itself. Other than that, you have the accessory ligaments, also called the suspensory ligaments of these, which is the spinomandibular and stylomandibular ligaments, and they serve as to some degree they passively restrain the mandible on being excessively opened. So the mandible, if it opens, it should open only to a minimal extent. So from that acts as a stop from preventing excessive movement of mandible. Okay. So the temporomandibular joint disorders, it goes with our regular of any disorders. We have to ask for the chief complaint, and then the onset and location of pain, the characteristic features of pain, so the aggravating factors and relieving factors, and then you have to, of course, you can ask the patient to grade using this visual analog score from 1 to 10. Okay, and then you have to ask for the past consultation and treatment. This is especially important because patients with the temporomandibular joint disorders, like the neuralgia patients, will be going from dentist to dentist, or they will have a very big reference list of starting from general dentist. I mean, this ENT people, they will go for ophthalmologist, they will go to neurologist, and then they will go to dentist, and then they will go to oral surgeons, and to all the people they would have gone. Okay, so because the presentability is very variant, and then the patient expects a quick relief, but it takes some time for the pain to settle. So notwithstanding the delay, the patient will be moving from doctor to doctor, which accounts for a bunch of medical history. They will be carrying literally a booklet of all the information collected from all the doctors. Okay, fine. So when you examine you have to examine the masticatory system also. The signs and symptoms of the temporomandibular joint are extremely common, because it is quite a common, other than your the infection and the other common dental problems. The patient can also come to a dentist for a temporomandibular joint problem also. So of which you have to rule out two things. If the patient is coming with a joint pain, or if the patient is telling a pain near the joint, after ruling out the other organic causes, you have to know whether the pain is because of muscle or the pain is because of joint. Okay, so masticatory system should be evaluated, which includes evaluation of occlusion, supporting structures, muscles of mastication, and of course the TMJ. So to be effective in evaluating, the sound understanding of the clinical appearance and function of masticatory system is necessary. Yeah, of course, it goes without saying. So on dental examination, check for the mobility of teeth, because with the patient is especially the posterior teeth are mobile, they will be altering the position to masticate. So such kind of alterations will have its repercussions in the temporomandibular joint. So you just have to evaluate regarding the periodontitis. And then the widening of PDL space on IOPA, whether there is osteosclerosis or hypercementosis, whether you look for the wear facets and for abfractions, and then occlusal examination, in which you have to evaluate whether there is a difference between centric and eccentric occlusal contacts. You have to evaluate the whether the whether to rule out any this cuspal interferences. Okay. So how to classify it? The TMJ, because maybe because of the disorders of the condyle, which may be developmental, traumatic, or neoplastic in origin, of which developmental you will come across very rarely, but traumatic, yes, you will come across it frequently with the history of fracture. And then bony union between the articulating surfaces, which is otherwise called as ankylosis, in which the entire joint fuses with the base of the skull. And neoplastic is quite rare. You would not come across much frequently. Okay. So in the disturbance of synovial apparatus, it can be because of acute inflammation, or it can be because of chronic inflammation. For example, rheumatoid arthritis and psoriatic arthritis. And then the disorders of meniscus. This would be much common. The meniscus may be displaced. So it can be with reduction or without reduction. The disorders of the meniscus, in which the meniscus is not working in a synchronized fashion with the articulating surfaces, is called as internal derangement. We will deal about it later. Okay. Then the disorders of associated structures may be a centrally mediated myalgia or muscle spasm. Maybe you are not able to virtually rule out any causes, or it can be because of a locally mediated myalgia. These are all those things are of related to patient's psychological status, no? The prolonged anxiety, prolonged depression, because of which the patient may be having nocturnal bruxism, which is again, you are giving extra load to the masticatory muscles, and then it can present itself as a muscle pain, which can mimic near the temporomandibular region. Okay, fine. So the classification of disorders, as I've already told you, it may be because of masticatory muscle, or it can be because of trauma. So those of the disorders with the masticatory muscles can be because of protective muscle splinting, because of muscle spasm, or because of muscle inflammation. So the trauma, under the trauma, you can have the traumatic arthritis, you can have the fracture, internal derangement, and then tendinitis, myospasm, and contracture of elevator muscles. So on the trauma, you can have either the joint may get loosened, which is the joint may actually get popped off the whole entire holding apparatus, which is it can come out of the articular eminence. It is called as dislocation, and then the joint get loosened. It is called subluxation, and there is collection of blood in the joint. It can be because of hemarthrosis, which you don't have to undergo an extensive trauma. Even micro trauma can cause bleeding inside the joint. And then you have this intra or extracapsular fracture. And internal displacement, you can have this anterior displacement, whether the disc is displaced anteriorly and then the condyle is able to override it or not. It is called as with or without reduction. And you have the arthritis, you have the general form of osteoarthrosis and rheumatoid arthritis and infectious arthritis. In patients with the recurrent medullary infection, that infection can there is a possibility that infection can spread from midbrain to the from the middle cranial fossa to the TMJ space, and then it can induce infectious arthritis. You have developmental defects with condylar aplasia, hyperplasia, and hypoplasia, and a bifid condyle. Ankylosis is a very common condition. especially when the trauma to the TMJ is not treated adequately or it has been overlooked. Neoplasm, as I've told you, it can be benign and malignant, but it is you very rarely encounter as such the neoplasm of TMJ per se in the clinical practice. Myofascial pain and dysfunction syndrome or mastication, we will deal about it. Now, diagnostic features is there is a unilateral dull aching and facial pain that is poorly localized. It is moderate to severe limitation of mouth opening. In this case, there is as such the temporomandibular joint is functioning properly. Only the muscles are not functioning properly. So there is this trismus is because of muscle spasm. Okay. So there is no TMJ tenderness, and then there is only muscle tenderness, especially the masticatory muscles and the cervical muscles. And hence, when you even take the radiograph for the TMJ, the patient will not show any, the picture will not show any evidential changes in the TMJ apparatus. So general characteristics. So funnily, I don't know how because now they have told that this is predominantly females are affected. Okay, then 20 to 40 year age group is getting affected with the frequent history of other psychophysiologic diseases, and then they suffer from chronic depression, which and then as I've told you, they will be going on from doctor to doctor. Every clinic they would have visited. Okay. And then they have most of these people have difficulty in accepting a psychophysiology as an etiologic agent for their disorders. This you have to keep in mind when you are doing prescription, because when you are even prescribing a drug to treat their anxiety, okay, you can tell them you should actually you need not reveal that I am treating your anxiety, but you can tell them this is for good sleep, or you can tell that this is for nutrient purposes, or this is for muscle relaxant. So this is just to loosen your muscles, so which will comfort them, or else you have a risk of every chance that the patient may not be complying with your prescriptions. Patient will just defer it, and then he has given me only the psychological antipsychotic drug, so I am not going to take it. So patient will come to a prejudice that this drug will not act on me. Okay, fine. So what is the psychophysiologic theory of MPD? So there is stress, which induces muscle hyperactivity, which causes the muscle to be fatigued, and it undergoes spasm, and hence the result of MPD. So you can these electromyographic studies can very well elicit they can depict the hyperactivity of the muscles of mastications when they are subjected to the study. So treatment is, you should know whether there is a myofascial pain dysfunction syndrome, and then start with the use of home therapy like hot water fermentation and other things, and medications for pain and anxiety. Your routine analgesics that we normally give, like our NSAIDs are good, but we have to be careful in prescribing COX-2 inhibitors. Okay, COX-2 inhibitors on long term, because these kind of people will be taking medicines for a long time. So this COX-2 inhibitors on long time, they have their cardiovascular implications. So let us avoid prescribing COX-2 to this group of people. So one thing which we have to know from which is different from prescribing analgesics to the other disorders, like for example post-extraction pain. If the extraction is very simple, we always tell the patient to stop the medicine once the pain is gone. So very oftenly we prescribe only SOS, that is only if necessary the patient can take painkillers. But in this case, you have to the patient's blood level have to carry the drug, the NSAID drug has to be achieved. The blood level has to be, pharmacologic level has to be achieved to suppress the inflammation. So the patient has to compulsorily take the drugs with a fixed regimen for a particular number of days. It ranges from 1 week to 40 days also. So we have to be careful in putting the patient in a long-term NSAIDs, which will have its own side effects. So this thing we have to be keep in mind, and then we have to make a judicious choice. And then bite appliances may be because of the as giving a rest to the temporomandibular joint, and then you can have the physiotherapy, and then relaxation therapy, and possible psychological counseling if there is a established psychological overlay. So what are the home therapy consist? So you can check for the clenching habits, and then you can advise the patient that they can be on soft diet for a period of 3 weeks, which will give a lot of rest to the muscles, and then that can improve the symptoms. And you can advise them isometric exercises for which is movement of pressing the mandible against resistance, which if there would have been a face-to-face learning, then I would have demonstrated what are isometric exercises. But anyhow, I will check for some video, and then I will post it in the Google Classroom. Okay. And then moist heat and massage of the jaw muscles, which to promote vascularization there, and then which can wash away the inflammatory byproducts. So to achieve that, you can have your moist heat and massage of the jaw muscles. So medications, mild analgesics for pain. You can have your NSAIDs. The common drug is ibuprofen. We can give muscle relaxants for anxiety. So you have to tell the patient that this is to just smoothen your muscles or loosen your muscles. So that the patient can get an adequate sleep. And then you can also prescribe the patient with amitriptyline. Okay. In addition to that, you can prescribe the normal muscle relaxant also, which can have a daytime sleepiness also. So we have to be we can weigh the risk versus benefit, and then you can, if you suspect that there is a muscle spasm, muscle relaxant prescribed will also resolve the problem. So dislocation of temporomandibular joint. I told you before, you can have odontologic emergencies, that is dental emergencies you can have in your practice. Is there a possibility of having dislocation of temporomandibular joint? Is there a possibility of having a TMJ emergency? This dislocation of temporomandibular joint is something which you are very likely to encounter in your practice, or when you are posted as a dental officer, you are very likely to encounter in your practice. At least once or twice in your practice, you will encounter this. Okay, so this is one of a very gratifying experience. If you are able to pick it up very earlier and then establish, and then you can reset the mandible, then the patient will be very happy after having the disorder removed. Okay, so just imagine that our class Edmund is very hungry. He goes to Edmund. He goes to Burger King shop, and then because of voracious appetite, he just orders for a double cheeseburger, and then he opens the mouth widely and then try to eat it, and then he opened so big that the entire condyle just traveled out of the articular eminence, and it does not know the way to go back. So this is called acute dislocation. Okay, this is called acute dislocation. We will see. So when there is a loss of integrity of ligaments associated with the joints, and there is a dysynchronous muscle function, and because of certain bony architecture which is very shallow, then you can have this dislocation, that is the joint moving out of its boundaries. This is called dislocation. Okay, so when all it can happen: yawning, wide opening, and seizure disorders and vomiting. All these things which are all the the activities which can open the mouth extremely wider beyond its capacity. In such cases, TMJ dislocation, acute dislocation can happen. So it can also happen during intubation of GA, or using gag during GA procedures. We have to be very careful in keeping the rubber blocks or bite blocks when you are doing the procedures. In oral surgery, we don't do it, but I have seen people doing in conservative also. So we have to be very careful when there is a prolonged opening. There is a chance that the TMJ, the condyle, will pop out of the confines, that is articular eminence. And then during extraction, when the patient is able to open the mouth wider, and then you have to perform the extraction, but you cannot ask the patient to overstretch. Okay, then the seizure disorders because of the muscle spasm, there can be because of flexion and extension, and which when they're severe enough, they can cause a trauma, and then there can be dislocation. So malocclusion, loss of dentition, when the tissue is very loose, hypermobility issues, and then when the patient is habituated, like an excursion, the condyle just comes out and then goes in. It becomes a hobby for him, and then that is kind of a habitual dislocation. And then antipsychotic drugs or phenothiazines, although these things can also, the CNS depressants can also cause TMJ dislocation. So this is what happening in the TMJ dislocation. You see, the posterior band is stretched. The condyle is when the patient is like attempting to open the mouth much wider, the entire translation of the condyle goes beyond the articular eminence, and then the condyle gets stuck between the articular disc and the anterior part of the eminence, in which the patient is not able to guide himself to get the mandible back in position. So the patient comes to you with an opened mouth. Many times there will be drooling of saliva because the patient doesn't know how to control it, because the patient cannot, the lips are also incompetent. So there will be drooling saliva. The patient will be extremely anxious. And remember, when there is a lag of time since the dislocation till the patient reaches your clinic, the longer the time, the severity is going to be, the severe the muscle spasm. So that will pose difficulty in manipulating the mandible back. So these things are all important. Okay, we had an experience of a case who was developed dislocation, plus the patient was in a remote village. So by the time the patient came to our clinic, it was the patient, all the muscle spasm was well established. We were not able to manipulate the mandible. We were not able to even move the mandible despite all of our efforts. But later on, we shifted the patient to the OT when they are intubating, and then they give us all those pre-anesthetic medications. The patient muscles got relaxed, and then we were able to easily set the mandible back. So timing is very important. Okay, fine. So how do you reduce it? So we have to do an downward and posterior pressure. Downward pressure will disengage that locked portion of the condyle, disengage, and then it can, when you move it posteriorly, it can just glide over the eminence, and then it can go back to the position. Okay, if there is would have been a face-to-face, I could have demonstrated this also in the class. Okay, usually I do it to the other students. Okay, so see, the doctor is actually holding bilaterally. So your thumb should rest on the occlusal surface. In order to avoid injury or in order to avoid pain, you can cover the occlusal surface of the mandibular molars with the gauze, and then you have to hold it bilaterally. You have to stand in front of the patient. You have to hold it bilaterally, apply a downward pressure which can disengage the head of the condyle, and then you push the mandible backwards. It will just go and set back. Okay, it will be a very gratifying experience for us, and then very relieving experience for the patient also. Okay, so fine. So after that, anyhow, we have to ask the patient to not to open the mouth. You can either secure with Barton's bandage, and then you can advise the patient on soft diets, and then the muscle, the other NSAIDs and other drugs can be given. So anyhow, such kind of things happen. You have to advise the patient on soft diets for at least 15 days. So other than this, your laxity of the MPD disorders can be MPD disorders can be treated with your physiotherapy, which includes ultrasonic therapy with Botox, which is paralyzing agent. So that is actually a toxin from Clostridium botulinum. It can paralyze the muscle, and then because of which the muscle spasm is already gone. So If it is very persistent, you can carry out the surgical treatment of lateral triggered myotomy or closed condylotomy and the ligation of the coronoid process to the zygomatic arch. I think these things will be discussed in the surgical management of temporomandibular joint, the last 3 points. So, as such, this pain and MPDS can present with trismus also. So, just to for completion sake, other than this, your infection, trauma, inflammation, the myositic ossificans, tetany, tetanus, neurological disorders, all these can cause your the patient with the difficulty of mouth opening. It is an essential clinical feature. It is a clinical feature. So of which this there is a mechanical blockage which requires only surgical treatment, and extra articular fibrosis will also require surgical treatment. So internal derangement. Internal derangement, what is internal derangement? So we know that gingival joint means the condyle will rotate inside the articulating force, articulating surfaces, and then for a minimal amount of mouth opening, it will give the hinge axis motion, and then while for mouth to open maximum, you can the condyle will literally move anteriorly. So this is like this articular disc which is getting interspersed between the articulating surfaces. It is like the convoy for the Prime Minister. Okay, so before the Prime Minister reaches the place, the convoy will reach the place, isn't it? You will get the siren sound, wah, 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 wah sound. Okay, before the VIP comes, there will be a group of security people and convoy which comes before them, and then before the Prime Minister leaves the function, the convoy will be ready already. So they will be always ahead. Just like that, the condyle is the PM now, and this disc is like the convoy. So when the condyle wants to move, the disc will move prior to the condyle, so that the condyle and the articulating surfaces will not get injured. Okay. When this synchronization is absent, there is something called internal derangement occurs. Okay, I have uploaded a video to understand this concept in the Google Classroom. I suggest you to watch it once again. Once you watch it, you will be able to picturize it, and then you will be able to remember it very clearly. It's quite simple. As such, they have explained it in a beautiful way. Okay, we will see about it. So there is an abnormal relationship which is existing between the disc and the condyle and the fossa and the articular eminence. So it is associated with these conditions such as synovitis. There is capsular scarring, there is hemorrhage inside there is bleeding inside the capsule, and there is fibrocartilaginous metaplasia, there is calcifications, and then there is osteoarthritis. So what can be the reason? Because of microtrauma and because of macrotrauma, there is something which is happening inside the joint capsule, which spoils the relationship between the articulating surfaces and the disc. The disc displacement results in stretching or tearing of the retrodiscal tissues, followed by degenerative changes, which is the retrodiscal tissues. I have already told you that they are rich in blood supply and nerve supply. Because of that, the patient is going to have excruciating pain during opening and closing. Okay, all these things are manifested with clicking, and then opening click and closing click will all these things will have your these things are of diagnostic importance. So there is pain during function, the mouth opening is limited in case of long-standing cases, and then there is masticatory and cervical tenderness because they are overexerting to adapt to the limited mobility of the mandible. So what are the classification of internal derangement? There is anterior displacement, in which there is the disc is anteriorly displaced, and which that returns to the normal position during mouth opening. So this is anterior displacement or disc displacement with reduction, and then disc displacement without reduction, and there is structural incompatibility in which there is the disc can be attached to the joint surface. So this is the different stages of the disc, anterior displacement with reduction. See, from the A, the B, the condyle wants to go out. The mandible, you want to open the mouth. The patient wants to open the mouth. So the condyle is overriding the disc and then resting on the intermediate zone. Now the condyle wants to go back. Actually, the disc has to go back, but the disc is not going back because it is getting stuck because of some adhesion issues. So the condyle just overrides the posterior aspect of the disc and then it goes back and sit, and then the disc lazily comes back. Okay, this is called as anterior displacement with reduction. When there is a returning of the condyle and the disc, even though there is a lag, it is called with reduction. That means it is able to reduce itself properly. But in case of long-standing cases, sometimes the disc may not come back, and then the patient will have pain. The main clinical feature being in your disc displacement with reduction, the patient will be able to open the mouth, but there is a clicking joint. There is a clicking sound. In case of the locking process, the mandible will not be, the patient will not be able to open the mandible, and it is that locking joint will be having more pain. Okay, fine. So this is the TMJ locking. So see, every time the condyle wants to come out and go back, the disc is in stationary position. It's very stubborn. Okay, it is like a wife fighting with the husband. I won't come with you. So like that. So the disc is already got stuck, and then it's not coming back. It is not work in harmony with the condyle. So these are all the various position just for you to understand the relationship of the condyle and the disc when there is a clicking and locking. More than that, if you watch the video, you will be able to get a clear understanding about this. Okay, fine. So there are various stages of this internal derangement which progressively disables the mandible movement. Okay, so there is stage 1 in which there is a reducing disc displacement, stage 2 there is late reducing disc displacement, and stage 3 consists of non-reducing disc displacement, and then stage 4 consists of non-reducing disc displacement, which is chronic, and then it goes for degenerative changes which leads to osteoarthritis, which comes in the stage 5. So this is the Wilkes classification. As the stage increases, the disability also increases. How will you manage this internal derangement? You see, the nature has provided with an adaptive capability that chronically, when this posterior band of retrodiscal tissues is getting repeatedly injured, nature will think that, okay, fine, this guy is going and getting interrupted every time, so let us save him, and then it is initiating an adaptive response, and then there is a pseudo disc formation. This posterior band of the disc, which is supposed to be innervated by muscles and nerves, nerves and blood vessels, it is undergoing an adaptive change, and then it becomes like the disc itself. It becomes cartilaginous. It becomes like cartilaginous itself. It is always called as a pseudo disc. So this pseudo disc. So this kind of patients who will have an excruciating pain during eating and wide opening and then closing their mouth, when you are able to manage it conservatively, this adaptive response can set in very earlier, and then the patient can avoid surgeries. And then these things can be very conservatively managed. Okay, so these are all the various modalities of conservative management: psychological counseling, occlusal splints, your antidepressants for pain relief, NSAIDs for pain relief. You have muscle reluctance to loosen the area on the intra-articular steroid injections to stiffen the articulating surfaces. All these things are aimed at keeping the joint at rest, so that the disc will try to automatically reposition itself, and then the symptoms will abate in due course of time. Okay, fine. So these are all the to start with, as an introduction to TMJ disorders, these are all the main conditions which requires conservative management. But surgical management is totally different. As I have told you, when all these preventive measures are being or not responding, that means which have become refractory, then go for surgical management, which starts from arthrocentesis. Arthrocentesis as such is not a surgical procedure in which you are not going to open up the temporomandibular joint, but you are going to wash the joint. Okay, arthrocentesis, arthroscopy, you want to know actually what is happening inside the joint, disc repositioning, disc removal with replacement, condylotomy and condylectomy. All these things are complicated procedures which will be discussed during the surgical management of TMJ, including you will be having an extensive discussion about the TMJ ankylosing, which is a very important essay, OSCE and whatnot. All this in all those aspects. Okay, fine. I think we have come to the conclusion. We have come to the conclusion of the lecture. So I suggest you to read the chapter very well, and then I would be, I think I will be giving you some questions to check how far you have understood. And then you read the pharmacological method of management very well. And then pharmacological method of management is important, and you have to have a clear idea of the classification of various stages of internal derangement that will be asked during your MCQs, and then that will be asked during your OSCEs mainly. Okay, fine. Okay, thank you. Have a good day, and then do post your queries in the Google Classroom or in the e-portal if you have any, and then you can contact me at whatever time. Okay, fine. Okay, bye bye then.